Thank you so much. My name is Stojanovska. Thank you. It was very close. And really thank you to organizers for asking me to come to this meeting. It is my first time and I really enjoy it. What I'm going to talk about is metabolic dysfunction. And I know that my topic was metabolic syndrome, but I kind of wanted to switch to metabolic dysfunction mainly because metabolic dysfunction is a continuum of cardiometabolic abnormalities that does not only include the traditional risk factors for metabolic syndrome, but also includes the chronic inflammation, insulin resistance, and ectopic fat deposition in places where the adipose tissue should not be seen. I have really nothing too much to disclose except that I was funded about 10 years while I was at the University of Michigan. My latest grant was Scale 2 before I moved to NYU. That started at 2019, but even before I was funded with smaller grants from the institution and also national grants to be able to get my time off and work on this particular topic. So I'll start with the one conundrum, and I think you would always look at this as how we can do a better job. So this is a patient with familial hypercholesterolemia, and you can see the CTA study that was done in 2017, and at that time the patient was diagnosed with the disease, and as I have pointed out, the LDL was very high at that time. So the patient was started on statins, and you can see how in 2018 the LDL dropped down significantly, was within the normal limits, and then the plaque, as you can tell, actually was present in 2017. 2018, the plaque was gone, so which means that the drug really helped. However, in 2020, the plaque is reappearing at the same level, and the LDL stayed low. So here is really the LDL a good marker to be tracking how the patients are going to do well over time, right? So at that time, I was thinking maybe we need to come up with a different biomarker that can identify how we can track patients with metabolic syndrome or metabolic dysfunction. And I actually did not even know that Svetlana Moisov will come with GLP-1 at that time, and both of us share same roots from the same country. Anyway, so what I would like to talk about, like why we need to talk and basically research a metabolic dysfunction, some of the research that has been done, and I will talk about my research and where the future directions really are. So this is a paper that I really, really liked it, even though I started changing my own lifestyle, but this paper it really confirmed what we need to do. And what this JAMA paper talks about, they have followed longitudinally a very large patient population within 20 years. At 10 years, they stratified patients on two groups, actually the population on two groups. One group was meat eaters, and the second group was non-meat eaters. So what they found after 10 years that patients who were converted to non-meat eaters, their mortality and morbidity decreased for 20%. So to me, that was reassuring that what I was doing, becoming a vegetarian, and I'm not suggesting that you need to become a vegetarian, because that also comes with other consequences, especially if you're a woman, which at that time I did not realize because my iron dropped significantly. And when women deal very differently than men, and at this particular paper, they did not point out and stratified based on sex. Anyway, so this is a very nice study that was published in New England Journal of Medicine back in 2004. So what they found is, and this is mainly women, right? So 12 women undergoing liposuction, right? They would do everything to make sure that they would look good, right? But all these women, they all basically had all of this cardiometabolic risk, as you can see, high blood pressure, CRP high, LDL high. So what they did this MRI, they measured their subcutaneous fat, as you guys can point out here. We see how big it was. And then liposuction, of course, get rid of the subcutaneous fat. But 12 weeks after, none of the cardiometabolic risks decreased. And why is that? Well, look at the visceral fat inside, did not change. So it's not only that we can do cosmetic procedures, do VeloShape, whatever. It's about going to the gym to make sure you lose that fat and make sure you eat quality work. So that is, the take point from here. And I'm like, well, I really want to help these women, right? I'm a woman, but not only women. I also want to help everyone to make sure they understand what the importance of changing lifestyle really is. So we know obesity is increasing and it's an epidemic. And even though I've pointed out here Michigan, because it really Midwest, it's more I would say, prevalent with obesity, whereas East Coast, West Coast, they're pretty lean. And I would tell you, I can read so many coronary CTAs, mainly because half of them are normal now in New York. So that's a good thing. People walk and pay attention what they eat. And this is another study from the National Health and Nutrition Examination Survey, where they said is that about 66% of the population, mainly this is in United States, published in JAMA, are either obese or overweight. However, 32%, which is every 1 out of 3 people in the United States are obese. So that's huge, right? However, another follow-up paper in 2005, they found that it's not really the BMI, but it's the central obesity, which is measured as waist, hip ratio or waist circumference, but not the BMI, is increased with the risk of cardiovascular disease death. So here it's, what is the traditional metabolic syndrome? How do we define it? So we define it, I'm gonna go scroll just so I can tell you can read most of the things, sorry. It's the central obesity. So if we're taking the metabolic syndrome as an iceberg, at the base we need to place the central obesity. This glycemia is at the tip of this metabolic syndrome iceberg, and they are all related or associated with development of cardiovascular disease. In this particular case that I have shown is the coronary artery disease. So another slide that I wanted to tell you, so this is the cardiovascular risk factors that we all heard about, right? So it's the lipid profile, hypertension, age, smoking, genetic factors, male gender, diabetes. However, the central obesity is the one that drives the global cardiometabolic risk. However, I would say the follow-up paper that I wanted to talk about is this, and this changed the whole spectrum. It's not at even the central obesity, nor everyone who is physically looked to be obese is really at risk for cardiovascular disease. This brilliant paper published in 2019 in Cell, what they showed, they found about 307 metabolites. And based on those metabolites, they have developed a metabolome signatures. And those signatures defined whether the patient is healthy obese versus lean obese, which means if they're lean obese, they're unhealthy, even though they seem to be lean, but there's something else in there. And what is that in there? Well, that is the chronic inflammation, which comes from the increased ectopic adipose tissue. So this is this now. So epicardial adiposity, that I will pay more attention to it, it's the fat that surrounds the heart. It's inside the pericardium, and I will go over that anatomy because I think it's very important. So as you can see here, the epicardial is the visceral pericardium, so inside, very close, attached to the myocardium. The pericardium is the outline, so it's not the same, and then everything that is outside the pericardium is the extrapericardial adipose tissue. They all have different embryology, they all have different vascular supply, and their function, it's even very similar. This was published in paper in 2007, just because you may see many papers will cite as a pericardial fat, but the pericardial will include both the extrapericardial and the epicardial fat. So this is how you can measure it. It's really anterior to the right coronary artery. That's the area that you can define first, where the pericardium is, and you can do all the circles around it, which now the AI tools can do miracles. I started out manually, to be honest, back in the days when my son was born, so that would be like more about 15 years. I started doing manually, and it took me about 15 minutes per case. And now I'm so happy that we can do that automatically. So these are the keys. Why we're looking at inflammation in the increased adipose depot. So you see how I have here, the adipocytes, they either hypertrophy or they undergo metaplasia, which means they will become bigger or they will increase in size. Both. It can basically happen. And with that, insulin increases, the leptin increases, adiponectin decreases, and the free fatty acids who are responsible for the inflammation are increased, and that leads to cardiovascular disease. I'm not going to go over this, some of the endpoints we can use, but let's talk about epicardial adipose phenotypes. Okay, so this is how I started out, because I wanted to look not only at the epicardial depot and quantifying the volume, but I wanted to look at quality. And for that, I needed MRI. And I know there are so many papers that talk about increased volumes, and I have done some, and I will show you they are correlated with AFib that was discussed, but I will really show you how deep you can go and look into the quality. So this was one paper published in 2009 and said that, if you can see here, that the patients in the epicardial space, they don't really only have white adipocytes. They also have brown adipocytes. And we all know that the brown adipocytes they induce thermogenesis, which means they're cardioprotective, right? So I was very curious to see what is in there. And therefore, I'm not going to go through this, but what we wanted to do is water fat imaging. So I asked my mentor, who is a PhD scientist, and he was so much into water fat imaging. Water fat imaging quantifies the ratio between the lipid and the water component within the pixel or the voxel, within the depot. So I was very curious. First experiment that we did was on mice. So we sacrificed mice that had a brown adipocytes, and you can see it here, right there. So these are all brown adipocytes, and then these are all white adipocytes, because the tissue in humans are not defined as only brown and only fat, but it's a mixture of both, right? So what we did, we defined like 3 experiments, as you can see it here. The red represents all white tissue. The blue, it's only brown, so we mixed them with the different concentration. And as you can see here, we were able to sparse it out between the 2 different tissues, whether the mice had only white adipocytes. That means the fat fraction will be higher. Why? Because the lipid content is actually higher than the water content. Brown adipocytes have more water content than they have lipid content. So we were able to sparse that out and show, yes, we can actually try it on humans. So let's see what we did. So this is how we scanned 2 of our patients. One was normal, and the other one was with metabolic syndrome. So here I have metabolic syndrome. Look at the area that I showed you, that is the epicardial adipose area. It's all red, right? So that means it's high with fat content. Whereas the patient right here, who was normal, it has more of a bluish and then greenish, right? So that is they still have both, but the fat fraction, when you quantify it, is not as high as the patient who had metabolic syndrome. So this patient had about, I would say, 60% of fat fraction, where this patient had about 90% of fat fraction. So very, very different concept. So here we took several patients where we had healthy. You can see the discrepancy, how shows a fat fraction between the epicardial, this will be the epicardial depot, and this is the subcutaneous depot. Because subcutaneous depot, it's all white adipocytes. Those cells are really big. And that's where the fat should go. And that is the reason why, even if we do central obesity or BMI, those patients that are healthy obese, they tend to deposit their fat in the subcu fat, but not in the visceral fat. And that's why this is very important. Look at patients with metabolic syndrome, right? So the epicardial fat fraction and the subcu fat fraction actually remains the same. Very, very close. I'm not going to go over this paper. That was one of the biobank paper. This is just to show that patients who actually over time tend to be a high worsening symptoms with metabolic risk or metabolic syndrome, they actually had a increased LV mass. So that's what metabolic syndrome can do, and they also had decreased LV strain, and also had a increased calcium score. But what I want to really talk about a little bit is the chronic systemic inflammation that we heard a lot about atrial dysfunction and AFib. They can have coronary disease and then also can have heart failure. So some of the things that we have done. So this is a paper that we published back in 2015. And what we showed with this Kaplan-Meier curve is that the patient with the highest volume of epicardial fat, they tend to have a increased AFib recurrence after ablation than patients who had a lower amount of epicardial adipose tissue. I'm not going to go over this because it was already discussed in length about atrial fibrillation, but I'm going to go switch to coronary artery disease. And I think this paper is really important. Even when I was trying to study, everybody will tell me, well, look at the visceral fat as meaning abdominal fat, right? But I'm like, well, I really want to look at the epicardial fat. So this paper was very good, published in European Heart Journal in 2009. And what they showed here, and I think I have, no, I thought that I have some markers here. But so what they really showed, if you're looking at here, at that time, they define epicardial fat as pericardial fat. So that was the definition before. And they looked at the visceral abdominal fat. So what they have found, as you can see here, that the ischemic heart disease and also the myocardial infarction, as you can see here, that the pericardial fat predicts ischemic heart disease and myocardial infarction a lot better than just the visceral abdominal fat. And why this is important? Because it's not the systemic inflammation, but it's more the local inflammation that it's important. And I know we touched base about the fat attenuation index. These are like one of the first papers that were published by Chari's group in Oxford. And I actually went there to collaborate with them for some of the lipids. And they looked at the pericoronary fat as a predictor of outcome. On a larger data set, they actually validated their tool that can predict cardiac mortality and also all-cause mortality. Coronary artery disease, as you can see here, is that, well, when the epicardial adipose tissue increases, those patients are at higher risk for developing coronary artery disease. But this paper is also important too, because they also looked at the calcified plaque versus non-calcified plaque. So what they found is that the patients who had a higher epicardial adipose volume are at higher risk for developing coronary artery disease in non-calcified or mixed plaques. And why is that? Is because the calcified plaque is irreversible process, but it's a chronic process, where the non-calcified plaque is still an acute event, an acute process that can be modified. Okay, so I'm gonna skip over this. This is like one of the studies that we did, but what I wanted to tell you is my project back in 2019, but it started in 2015, was more about looking at patients who had open heart surgery. We took tissue specimens from the subcutaneous adipose tissue, mediastinal or extrapericardial, and also pericardial adipose tissue. So we were looking at the fat composition, correlating them with the fat fraction that I showed you. So we did lipidomics and transcriptomics in this patient population. So with the hierarchical clustering, which you can see it here, you can see how the epicardial area, space, the lipids, so here we had so many lipids that were correlated with fat fraction. You can see it here on the right-hand side. And the epicardial adipose was closely related to the extrapericardial depot, but completely different than the subcutaneous depot. So the lipids inside there are completely different. And that is an important thing to distinguish, because even when we did the cell analysis, those cells were very, very different between all of those depots. And what we found, okay. So what we found is that the ceramides were one of the key components. And I will just go here. We looked at transcriptomics too. It turned out that the insulin signaling was increased in the epicardial depot in these patients who underwent CABG. And inflammation as well. One of the things that I kind of wanted to wrap up with is this particular one. So we looked at patients with heart failure with preserved ejection fraction, where we found that if here you can see it, fat fraction is higher, so more than 80%, those patients had decreased contractility and their tissue phospholipids were decreased too. Phospholipids are very important to keep the cell intact, which means if they're not here present, those cells are prone for apoptosis. So I know that I don't have too much time. Several things that I kind of wanted to cover, but I'll go to future direction, is that we need a diagnosing companion in response to lifestyle intervention and some therapy. And then that will be a diagnostic tool to predict patients' cardiovascular disease outcome. I'm so happy AI is here. And then the link with between epicardial adipose systemic inflammation can also affect other organs too. So liver, kidneys, lungs, brain, etc. So just make sure you eat well and you exercise to keep yourself out of the trouble. So thank you so much. And this is the team that I work with.